Thank you, Christina and Heather. Over the next 20 minutes, we're going to focus on the role of multimodality cardiovascular imaging, in particular, the complementary roles of echocardiography, cardiac CT, and cardiac MRI in the non-invasive diagnosis of apical cardiomyopathies. I have no disclosures. With respect to the outline of today's brief talk, we're going to focus on 4 key items. 1, an introduction to the various complementary imaging platforms in 2020, followed by the diseases that are associated with an apical cardiomyopathy, specifically LV non-compaction, apical hypertrophic cardiomyopathy, and then finally other apical disorders of the heart that one must consider in the differential diagnosis. In 2020, we currently have 4 complementary imaging modalities in terms of echocardiography, MUGA scan imaging, cardiac CT, and cardiac MRI, which has its own strengths and limitations, providing complementary information in our evaluation of patients with cardiovascular disease. This is a summary table that I have created that shows the various features of the 4 imaging modalities: echo, MUGA, CT, and cardiac MRI. The first feature is that of spatial resolution, which refers to how fine of a detail can you see. One can clearly identify that cardiac CT has the highest spatial resolution of 0.4 to 0.5 millimeters, which allows us to assess the coronary anatomy non-invasively using this imaging technique. Cardiac MRI has a spatial resolution of 1 to 2 millimeters, followed by echocardiography, both transthoracic and transesophageal echocardiography, which is up to 3 to 4 millimeters. Then we move on to temporal resolution, which refers to how fast of an image can you see. It's very similar to the shutter speed of your camera. You can see where the Achilles heel of MUGA, CT, and MRI is a frame rate of only 10 frames per second. Echocardiography, both 2D, with frame rates of up to 100 frames per second, and M-mode echocardiography of 1,000 to 5,000 frames per second truly is advantageous, especially with individuals who have abnormalities with their valves that are moving very quickly, where you want to see pathology such as endocarditis, that you should be using echocardiography. Then we move on to portability. One can see that as we have come over the past 30 years, echo is becoming much miniaturized as compared to MUGA, CT, and MRI. Radiation is a key element. One must note that echocardiography and cardiac MRI are not associated with any radiation exposure. However, both MUGA and cardiac CT are associated with radiation. Specifically, if you look at the number of millisieverts, MUGAs are associated with about 5 millisieverts, which equates to about 50 chest x-rays, and cardiac CT, prospective that is anywhere from 10 to 20 chest x-rays. Finally, with respect to renal impairment, one must remember that if individuals have a reduced eGFR, cardiac CT and cardiac MRI cannot be performed in these individuals if you need to administer contrast agents, as opposed to echocardiography and MUGA, where it is safe to give these procedures. With respect to echocardiography, this continues to be the workhorse of imaging in 2020, where non-invasively one can clearly identify the LV systolic diastolic function, whether there are valvular abnormalities in the patient, as well as pericardial disease, all in one limited study. With respect to MUGA scans, they are very useful in the provision of accurate LV ejection fraction values, in particular in individuals that are receiving anthracycline-based chemotherapy in the cardio-oncology realm. However, in the setting of apical cardiomyopathies, MUGA scans have limited use. With respect to the role of cardiac CT, although it is very useful in the assessment of coronary anatomy stenosis non-invasively, there is a role of cardiac CT in individuals for the diagnosis of apical cardiomyopathy, in particular when the transthoracic echocardiographic images are suboptimal and or the patient has a contraindication to cardiac MRI. And finally, there is cardiac MRI, which non-invasively can provide us accurate assessment of LV volumes as well as ejection fraction, in particular with patients with apical cardiomyopathy. And the true strength of cardiac MRI lies in its ability to non-invasively assess tissue characterization. In particular, after the administration of gadolinium agent into patients, we can image the heart 10 minutes later. In brief, if you see that the myocardium is black, that represents healthy tissue. However, if the myocardium turns white, that suggests that there may be a degree of fibrosis or scar in the patient, and this is very important in the patient population with apical cardiomyopathies, as we will see later in the current presentation. Now that we have a brief understanding of the various cardiovascular imaging platforms available to the clinician, and in particular the strengths and weaknesses of echocardiography, MAGA scan, cardiac CT, and cardiac MRI, let's focus on the most common apical cardiomyopathy that one wants to evaluate, that being LV non-compaction. Using a case-based approach, the first case is that of a 44-year-old female who has a past history significant for hypertension, elevated lipids, and a smoking history. Over the past 3 months, she noticed that she has New York Heart Association functional class 3 symptoms where she has difficulty climbing up a flight of stairs. She describes two-pillow orthopnea, new onset paroxysmal nocturnal dyspnea, and she has noticed bilateral pedal edema where it's difficult for her to put her shoes on. With respect to her vital signs, her blood pressure is 140/70, right arm. Her heart rate is 92 and regular. She does have an elevated JVP that's 6 centimeters above the sternal angle. She has normal first and second heart sounds. She does have an audible third heart sound, and there are no cardiac murmurs. When one evaluates the 1280 kg, there is a nonspecific interventricular conduction delay. As we review our transthoracic echocardiographic images, in particular the 4-chamber view without and with color, one can clearly see that there is increased trabeculations present at the LV apex, and in particular when we place color Doppler, there is presence of intratrabecular recesses with color that goes within these spaces. To further, when we focus on the apical 2-chamber view, again without and with color, one can clearly identify that there is increased trabeculations at the LV apex and that there is color Doppler that goes and flows within the intratrabecular recesses. As the patient had new symptoms of shortness of breath, a cardiac catheterization was performed which revealed no evidence of obstructive coronary disease involving the left side system nor the right coronary artery. And finally, a cardiac MRI was performed which revealed evidence of excessive trabeculations noted towards the LV apex, as can be seen on the current CMR images. With respect to left ventricular non-compaction, it is a rare with estimated prevalence of approximately 0.2%. In terms of the embryology, it's the arrest of normal embryogenesis of both the endocardium and myocardium that leads to prominent trabeculations and deep recesses, as can be seen in the figure diagram. As echocardiologists and our sonographer partners, what does one evaluate on echocardiography for LV non-compaction? One wants to see if there is evidence of prominent ventricular trabeculations, deep intratrabecular recesses, as well as LV dilatation with reduced LV systolic function. Now, there are a number of echocardiographic criteria. We're going to focus on one by Jenny et al. That was published in 2001, where we want to see if the ratio of the non-compacted to compacted myocardial thickness is greater than 2 at end systole, see if there's trabeculations located within the mid-lateral, apical, and mid-inferior segments, and finally, if there's evidence of color Doppler flow within deep perfused intratrabecular recesses. In addition to the Jenny et al. Criteria, this is another criteria by Stolberger and colleagues from 2004. With respect to diagnosis of LV non-compaction echocardiography, they want to see greater than 3 trabeculations protruding from the LV apex, trabeculations with same echogenicity as the myocardium with synchronous movement, perfusion of intratrabecular spaces from the LV cavity, and their ratio of non-compacted to compacted myocardial thickness was greater than 2 at end diastole. On the current slide, we have additional representative echocardiographic images here where the non-compacted to compacted myocardial ratio is greater than 2 at end systole. In addition, one can see that there's evidence of prominent trabeculations and that there is color Doppler flow within the intertrabecular spaces. In those patients with poor acoustic echocardiographic windows, one can administer contrast agents for LV opacification, as can be seen by this representative figure from Oshlin and colleagues demonstrating the hypertrabeculation towards the LV apex. Now, one must remember that there are limitations of echocardiography in the non-invasive diagnosis of LV non-compaction. This was a paper published by Coley and colleagues in the European Heart Journal in 2008, and they commented on the following three key elements. The first is that three different echo criteria, Chin et al., Jenny et al., and Stolberg et al., were derived from very small patient populations. The second is that the criteria are not validated in different ethnic groups. Up to 10% of actually healthy black controls in the study by Coley et al. Fulfilled one or more diagnostic criteria for LV non-compaction. And finally, when one sees abnormal trabeculations, you need to make sure that you don't mistake them for normal myocardial trabeculations, which is less than 3, false tendons, aberrant bands, as well as LV apical thrombi. Now, transitioning to cardiac MRI, there are two diagnostic criteria that are often referenced to. One is the Peterson et al. Criteria from 2005, where they look at the ratio of non-compacted to compacted thickness greater than 2.3 at end diastole in the horizontal long axis view, with sensitivities and specificities as labeled there. The other is diagnostic criteria by Jacques et al. From 2010, where they focused on the trabecular mass within the LV greater than 20% of total LV mass on short axis view at end diastole, and this has a sensitivity and specificity of 94%. On this slide, we can see representative cardiac MRI images where on the left, we see a 4-chamber view demonstrating the hypertrabeculation involving the lateral to apical segments. And then in the coronal view, again, we see the excessive trabeculation involving the LV cavity. As described earlier with respect to the role of gadolinium administration in cardiac MRI for tissue characterization, in individuals with LV non-compaction, if there is enhancement of the LV trabeculations, this can serve as a substrate for increased arrhythmogenesis in this patient population. In individuals who have poor echocardiographic acoustic windows or contraindications to undergo cardiac MRI, cardiac CT can be used in the non-invasive diagnosis of LV non-compaction. This study by Sidhu et al. From 2014 evaluated CT use in 8 patients with LV non-compaction and 11 individuals with non-ischemic dilated cardiomyopathy. Using the diagnostic criteria for Jenny et al. On echocardiography or the Peterson et al. Criteria on cardiac MRI, they did 64 slice CT with retrospective gating in this patient population. These are representative CT images in their patient population where one can again clearly see, in particular on the right, the ratio of the non-compacted to compacted myocardium that is suggestive of LV non-compaction. With respect to the current Venn diagram comparing normal variants and the overlap with LV non-compaction, one must remember that the disease should not be diagnosed by imaging alone. One should focus as the clinician on symptoms. Does the patient have a history of shortness of breath as well as syncope? Is there a family history of sudden cardiac death? Are there abnormal EKG findings such as T-wave inversion or left bundle branch block that make you think that this patient may have an underlying cardiomyopathy? On echocardiography, the patient may have a decrease in the lateral E prime less than 9 centimeters per second. There may be a decrease in the EF on exercise echo, as well as abnormal myocardial strain parameters. And finally, in addition to cardiac MRI, if there is evidence of late gadolinium enhancement, this may be suggestive more of LV non-compaction. Now that we have a clear idea of the various cardiovascular imaging platforms and specifically how do we diagnose LV non-compaction using echocardiography and cardiac MRI, let's focus on another apical disease, that being apical hypertrophic cardiomyopathy. In the second case, we have a 51-year-old gentleman who has a past history significant for hypertension. He has a witness out-of-hospital cardiac arrest and is resuscitated from ventricular fibrillation in the field. En route to the hospital and on telemetry, there's evidence of significant PVCs. On examination, his blood pressure is 140 over 80 in the left arm with a heart rate that's 82 and regular. His JVP is normal. He has a normal first and second heart sound with a diastolic fourth heart sound, and he has no cardiac murmurs. On this 12-lead EKG, if we focus our attention to the precordial leads between V1 to V6, we can clearly identify that there are significant T-wave inversion abnormalities present. On the current parasternal long axis view, the LV systolic function is preserved and there's clear evidence of hypertrophy that progresses towards the LV apex. On the apical two-chamber view, the LV wall thickness measures up to 16 millimeters, and if we check the ratio of the apex to posterior wall, it is greater than 1.5. With respect to apical hypertrophic cardiomyopathy, we know that HCM is an autosomal dominant disease of the myocardium caused by mutations in one of 9 genes that encode the sarcomeric proteins. With respect to apical hypertrophic cardiomyopathy, it is rare with hypertrophy that is focal localized involving the LV apex. In 1976, Sakamoto and Yamaguchi described this with giant T-wave inversions with spade-like deformity of the apex on left ventriculography. Note that apical hypertrophic cardiomyopathy represents up to 25% of the entire hypertrophic cardiomyopathy population in Japan, as opposed to only 1 to 3% in the Western world. The clinical presentation of apical hypertrophic cardiomyopathy can vary from being asymptomatic as an incidental finding to severe manifestations including sudden cardiac death, lethal ventricular arrhythmias, as well as an apical infarction. With respect to echocardiography, the diagnostic imaging that one must focus on is asymmetric LVH confined to the LV apex, an apical wall thickness that is greater than 15 millimeters, and then the ratio of the maximal apical to posterior wall thickness greater than 1.5. In the apical 4-chamber view and the apical 2-chamber view on this echocardiographic images, there's evidence of hypertrophy towards the LV apex consistent with apical hypertrophic cardiomyopathy. These are representative cardiac CT images showing again the same diagnosis of apical hypertrophic cardiomyopathy where there's significant LVH towards the apical component. And finally, on cardiac MRI, in both the vertical long axis view or 2-chamber view and the horizontal long axis view or the 4-chamber view, there is evidence of this ace of spade deformity present within the LV cavity with apical hypertrophy consistent with the diagnosis. And as previously mentioned, following the administration of gadolinium, one can characterize the tissue as can be seen on this cardiac MRI. If we focus our attention on panel D in particular with the arrows, although the myocardium should be black, which is healthy, we can see that there is evidence of white fibrosis, which increases the risk of the patient to have an arrhythmogenic substrate in this diagnosis of apical HCM. Now that we have an increased understanding of the various cardiovascular imaging platforms, how and when diagnose LV non-compaction, and then finally apical hypertrophic cardiomyopathy, what other apical impostures must one consider in the differential diagnosis of apical disease? This is an example of a linear density present within the LV apex that originates from the interventricular septum towards the lateral wall, and this is consistent with an LV apical false tendon. This is a focused apical 2-chamber view where we can clearly see a large echo-dense mass consistent with a thrombus in an individual post-myocardial infarction. This is a cardiac MRI of a patient with an LV apical thrombus, and when one looks at the gadolinium-enhanced images on the right, one can clearly identify that the mass does not enhance, which is in keeping with thrombus. On this echocardiographic images without and with contrast, this is an individual who presents with myalgias and found to have evidence of increased eosinophilic count on their blood work consistent with hypereosinophilic syndrome. And finally, this is a unique case of an individual where in echocardiography, one can appreciate that there are multiple echo-dense masses that are present within the LV apex. When we did cardiac MRI on this patient, we can see that there are multiple thrombi that are present within the LV apex, in particular involving the distal interventricular septum. On the T2 images on the left, we can see the masses that are present within the interventricular septum and lateral wall that are hyperintense and white. And when we give gadolinium to this patient, we can see that the masses do highlight. Finally, this is the representative PET scan of the individual, which shows that those masses that are present within the LV interventricular septum lateral wall do light up. And in the end, this patient was diagnosed with a peripheral malignant nerve sheath tumor that originated from the axilla that metastasized to the chest into the myocardial itself. So over the past 20 minutes, we have focused on one, the cardiovascular imaging platforms that are available to us in 2020. Second, how do we diagnose LV non-compaction using echocardiography and cardiac MRI? Third, how does one diagnose apical hypertrophic cardiomyopathy? And finally, other apical disorders that should be considered within the differential diagnosis. At the end, the take-home message is the following. In the diagnostic workup of an apical cardiomyopathy, LV non-compaction and apical hypertrophic cardiomyopathy are top two diagnostic entities to entertain within the differential diagnosis. One must remember that echocardiography, with contrast in particular, and cardiac MRI are the two main imaging modalities. And in the differential diagnosis of apical impostures, please do not forget false tendons, an apical thrombus, hypereosinophilic syndrome, as well as malignancy. Thank you.